Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. Well, hello, everyone. And this is probably going to be the most exciting episode of 2026, certainly for me, but you could disagree. So at the end of the year, we'll take a look. And the reason why I think this is going to be the most exciting episode of 2026 is because I'm about to show you something truly extraordinary, something that has been inspired by hundreds of patients, by thousands of questions, and by the real need for patients, people, us, to get personalized care. You see, I have read an article not so long ago. You can see it in my Substack newsletter called Vital Signs and Bottom Lines. And it was an article from the European Heart Journal. And it was discussing what are the options for patients, adults who are found to have elevated lipids, elevated cholesterol, and what are the strategies that cardiologists need to exercise with those patients that we can actually help them to avoid heart attacks, avoid strokes, avoid cardiac deaths. And the authors, they structured this article as a debate. So there was one group that said the best approach, they said, is called fire and forget it. And, this is what I called my article in Substack. I called it Fire and Forget Rebellion. And so what this group is saying is that, look, we should not be having a whole lot of the discussions because medications work. And we know we need to use medications to reduce occurrence of so-called major adverse cardiac events, or MACE. Medications do work. Sometimes they have side effects, but they do work. And in situations where resources potentially are limited, where we have to address this tremendous burden of heart disease, we need to deploy all the things at our disposal. And that really means getting those medications, prescribe them to a patient, and even if they don't follow up, so what? And then there was another group of authors, a good friend of mine, Dr. Regina Druz, who is local to us, who is a preventive cardiologist. And she argued, she said, look, patients are increasingly asking for personalization. They're asking for genetic data. They're asking to understand what strategies they can use comprehensively to lower their cardiac risk. And so the reason why I think this is going to be the most watched episode of 2026 is because you are listening to this or watching this on YouTube in February, which is Americans' Heart Health Month. You see I'm wearing red to celebrate Americans' Heart Health Month. And I want to show you something that I'm very proud of because we just launched it at the Holistic Heart Centers. And I think it's truly has been helping our patients, and it will help you and your doctors, if you're not our patient, to actually bridge the gap between this fire and forget strategy, just, throw the drugs in the kitchen sink on anyone who has high cholesterol, and the need for people to understand how they can personalize, how they can address their unique, specific risk individually, something that they may not be doing well right now. And that is exactly the questions that we've been asked numerous times. And this is exactly the type of patients who often come to us at Holistic Heart Centers. They're not just looking for a prescription because they have it already from their doctor. They're looking for this comprehensive, personalized deep dive into their situation to figure out what is it that they should or should not be doing. And let me tell you something. Every day, and we've seen over 1,000 patients at this point, every day there are sort of same types of questions that are being asked. And these are the same questions I ask myself. And I'll tell you why. It's not because I'm a physician who interacts and partners with our patients to help them achieve their health goals, but because I'm a patient as well. If you have listened to my previous episode, you know that approximately 2 years ago, I was diagnosed with early stage breast cancer. I was very fortunate. It was found early. It's basically what they say is curable, or cured. They took it out and, gave me some radiation therapy and put me on tamoxifen, which is, a very common medication that is used in those, cases, including low risk cases. And so what happens is that every day I, take this pill, this tamoxifen pill. And every day when I come to this bottle, and if you're listening to us, I'm showing the bottle right now. If you're on YouTube, you will actually see me showing it. Every day when I take this medication, I ask myself, will this work for me? Right? There are clinical trials that show that women like me have a substantial risk reduction, and it's all highly relevant, but that's a group of people, and I don't really know, is this group of people really representative of me? Or am I different? And how am I different? So I ask myself this question, will this work for me? And I know this is exactly the question you're asking yourself. If you're being prescribed a drug, for example, for high cholesterol, whether it's a statin medication, whether it's injectable such as Repatha or any non-statin alternatives, whatever those things are, you are asking yourself every single day, will this work for me? And what does it mean if this is going to work for me? Does it mean that you are not going to have a heart attack? Does it mean that I'm not going to have cancer recurrence? Does it mean that you're going to have a life filled with energy and vitality where you're able to do everything you want to do? Does it mean the same for me, that I will be able to maintain my function and optimize my function even as I get older so that I can enjoy my life and, enjoy all the things that life brings to us? Is that what it means? Or does it mean something else? And the second question that I know you are asking, and I ask myself the same question every single day when I do take this medication, is what else should I be doing in order to reduce my risk of this disease recurrence? And I know what our patients are asking. They're asking what else they should be doing in order to reduce their own risk of having a heart attack or having a stroke or having another, heart event, for example, right? How can they avoid one and what else they should be doing in order to prevent one, right? And most of you already know that medication is not going to be enough. It is powerful. It plays a role, but it's not necessarily going to be enough. There are a lot of other things that you can be doing and probably should be doing. And if you listened to my podcast before, you know what they are. We talked quite a bit about various strategies, fasting strategies, various strategies that have to do with reducing inflammation, hormonal replacement strategies, and we're just scratching the surface, right? Because this year we're going to talk about how to measure your immune system age, your inflammation age, how to actually understand through deeper biomarkers how to forecast your risk. And this is what I want to focus on today. You see, you and me, we're asking the same questions. We're asking the same questions because you and me are both presented with a situation where we have been marked by our health condition, whether it's coronary artery disease, high cholesterol, high blood pressure, early stage breast cancer like me. We have been sort of put in a specific category, right? And it's within that category that these questions ask. And, we sort of come up with, the need is there for us to understand beyond the sort of common trials, beyond the population-based metrics. What is it that you can be doing or should be doing? What is it that I can or should be doing in order to significantly impact my health span and my lifespan, even though I already have one of those diseases that when we talk about health span and lifespan, we really don't want to have, right? And so when it comes to cardiovascular disease, and especially discussing it right now during the Americans' Heart Months, it still continues to be the number one killer of both men and women, right? There is statistics is there. You can look it forward and backward, and you know that it's going to tell you exact same thing. Sometimes we do a little better, sometimes we do a little worse. But idea is still the same in developed countries, and actually in some of the developing countries right now, cardiovascular disease, vascular disease, continues to lead the charts with regard to mortality, that's death, and actually a lot of it translates into morbidity, which basically means the implications from cardiovascular disease. And some of the types of cardiovascular disease that are rapidly expanding, especially in women, go beyond coronary artery disease and go into heart failure syndromes and sort of specific gender syndromes where physiology is less well understood and typical medications may not be as helpful. And very often these women, for example, spend years or have very difficult time getting diagnosed. And I'm talking about conditions like sudden coronary artery dissection that usually is found at angiogram when everyone thinks that a person is having a heart attack, or Takotsubo cardiomyopathy, a very special sort of type of cardiomyopathy that pathophysiologically is related with the cardiomyopathies, weaknesses of the heart muscle that we see, for example, in patients who are pregnant or patients who recently had a baby, right? The so-called peripartum cardiomyopathy. But I want to shine a spotlight today on risk as a concept and show you a tool that you can use either with us or with your doctor, doesn't really matter who you use it with, to really close the gap between what we know happening in the populations and what may be happening in you, right? Because when my doctor tells me, Regina, take this medication, it reduces the risk of recurrence by 50% in women like you. What she doesn't know is that how close I am to those women that were studied in clinical trials, right? The real Regina is here. Those women have been studied over a certain period of time. Research data is there, but I may or may not be somebody who follows in the same path because my physiology, my biology is different and it's unique. I have a unique set of exposures that maybe some of those individuals didn't have. And the same is true for coronary disease, right? We want to know, we want to understand, is there actually something which is very specific, very unique about you, and what should be the tools, the levers that you should press on in order to materially, significantly impact your cardiovascular risk. You see, one of the most important questions that people are not asking when it comes to heart health is, what is my cardiac risk, right? People are asking, what is my cholesterol? What should my cholesterol be? What is my blood pressure? What should my blood pressure be? What is my weight? What should my weight be? But we have to put it all together because at the end of the day, these various influences combine and compound each other, and they translate into something called cardiovascular risk. And there were at least 3 episodes in 2025, maybe 2024, that you can listen to on cardiovascular risk. You can listen to episodes about calcium score. It talks a lot about the cardiovascular risk. But let's really make it simple, right? How do we understand, how do we derive this concept of cardiovascular risk? Well, we know that some of these so-called traditional risk factors, some of them already mentioned, high blood pressure, diabetes, elevated cholesterol, obesity, family history, which is sort of a powerful risk factor that we don't necessarily know exactly how much of influence it could exert in each particular situation, but some situations are different from others. But we know that these traditional risk factors are very powerful because they do predict a certain risk of having coronary artery disease, specifically having heart disease events. We call them major adverse cardiac events, and those are usually classified as non-fatal myocardial infarction. So it's myocardial infarction, but person doesn't die from it. Or what we call sometimes strokes are included into that calculation, or cardiac death, right? This is a vascular event that person unfortunately does not survive. And so we have created these models in cardiology where we have so-called standardized risk estimates. They are deterministic models, so they are equations. And these equations came about from studying large groups of people. For example, very famous Framingham heart study that's been going on for quite some time, and Framingham offspring study. It's sort of been continuous. Another study called multi-ethnic study of atherosclerosis that used imaging such as calcium score to allow us to understand a little bit better how can we zoom in on a person's risk determinants in each individual's situation. What is driving the risk? What is forecasting the outcome for this person, right? The problem is that while it's a great concept, none of these concepts are comprehensive enough or complete enough to really give us a very strong and powerful estimate. It could give us a group level estimate, right? So if you're in a low risk group, intermediate risk group, high risk group, it sort of puts you in a certain category, but it then kind of makes you think that that's all there is to it, right? That's sort of the ceiling and you shouldn't know more. But I argue that this estimate based on the population metrics is only the floor. The ceiling has not been determined yet, because on that floor, we have to put now your individual predispositions, things such as genetic information, things such as information about the status of your blood vessels right now, your vascular age, your imaging data. We have to loop all of this in order for you to actually understand what your risk might be. Yes, it is still a statistical projection, but it is better than trying to fit you to a group of individuals that you may or may not belong to, right? Just as my doctor is trying to fit me into a group of women who are similar to me, she's not taking any of my individual characteristics into account because she really can't. That information doesn't exist, right? Somebody needs to come, collect this information, bring this information somewhere, analyze it, and then refine what otherwise is more of a crude statistical probability to make it more applicable to an individual, right? And that's where the major gap exists in cardiology right now, in oncology, in neurodegenerative diseases. The gap is formed by research data that we have accrued from studying large patient populations, doing research studies, some of them fairly long, fairly expensive, forming different registries, and the fact that the life doesn't stay still. So on the other side are patients like you, patients like me, people like us who are living with these diseases every single day, and they are doing things or they have individual things that are not really captured by this research data. So there is a huge gap between what we know and what we learn from these massive clinical trials or registries and what actually is happening with a person in real life right now, right? So this gap needs to narrow. And so one of the things that we have pioneered at the Holistic Heart Centers is that we pioneered structured programs that allow us to begin to close this gap, because we look at advanced biomarkers, at very comprehensive genetic panels, at imaging parameters that are grounded in figuring out your vascular age, your atherosclerosis progression, and even collect information, let's say from digital biomarkers, things that measure your body composition and your heart rate and your HRV, and we pull it all together to really create a personalized interpretation of your unique risk profile. We don't throw aside the population-based metrics. That's sort of the floor, right? We start there. When you come to us and you say, well, should I take this drug? Should I not take this drug? Or I have high cholesterol. I don't want to be on a statin. Can you do something about it? We have an answer for you, but this answer isn't sort of, yes or no. This answer depends on what is it that we're able to determine about your own personalized risk of having heart event versus taking the medication and having side effects. And so that you can form the best decision we can under the circumstances to either choose medication or choose a little bit less of medication with supplements and only do supplements. And of course, what other lifestyle interventions we can actually go on and execute, right? And we've been pretty successful with this strategy. So it's time right now in 2026, in honor of the American Heart Month, this is, coming into the world is, our beta version of your personalized cardiovascular risk estimator, right? It is called Heartwell AI. Website is heartwell.ai. I'm going to show to you in a few minutes. And it crystallizes hundreds of data points that have come across us from our patient histories and our patient journeys to really give you an opportunity to begin to fill the gap between these population-based metrics that traditional cardiology and primary care is really based on, and the individual themselves who may or may not fit into these population categories, right? And the reason why this tool is very important is because it's highly actionable, because I want you to understand how it works, and you can use it during your visits with us. You can invite your physician so that they can use it with you. In honor of the American Heart Month, we're actually going to make access to this tool free for all patients who we see in the month of February. So this will just come, as part of your visit, and you'll get this report. So what I want you to do is to understand how it works and why it works. Now, this is going to be a little technical, right? Not in terms that you don't need to do anything. If you are listening to me right now on your favorite podcasting platform, please keep on listening. But if you have any time, even just a few minutes, please hop onto YouTube, because this is visual. And so I wanted to show it to you so that you understand exactly how it works. And so we are going to jump into this very interesting tool. And like I said, it is called Heartwell.ai. So you see it here, right? And it is currently a professional version only, but you can, if you are a patient listening to us, you can go to Heartwell.ai and click this little button, invite your doctor, and you can send your doctor just a link to our website. Or if you have their information, please populate their information, and we will actually reach out to your doctor on your behalf. We will let them know that you have an interest in using this tool, and your doctor can start absolutely for free. There are 10 free assessments. So, they can test drive this with your information as long as you give them consent. And that way, they're not paying for this. So what we did with this tool, what I did with this tool, why it was built, because I wanted to bring comprehensive cardiovascular risk assessment. I didn't want patients just to have these random numbers that we can generate from population-based equations. And we can generate quite a few of them. And remember, I said, this is our floor. This is where we start. This is the best of what we can do, based on the accrued body of information, based the research that was done, based on the decades of work by very persistent and talented individuals who even gave us this framework that cardiovascular risk exists, that we need to track outcomes, right? But what I wanted to do is to bring an opportunity for personalization and for simulation of an intervention. Because a lot of patients say, well, I don't wish to use medications. I don't want to be on a statin drug. I don't want to be on Repatha. Is it too much? Is it too little? Right? So what I wanted to show here is that how you can make this decision in consideration with your doctor. Now, you probably have guessed already that since it's called Heartwell.ai, a lot of it is AI driven, and AI actually made it possible for me even to create something like this. But the information that it provides is not coming from a black box. We actually have a very solid methodology where we use validated risk models. Those are the equations and your calculations that your doctors are doing when you're in a visit with them to give you this measurement, this population-based metric of cardiovascular risk. And we bring those validated risk models and we pull on the research that is constantly accruing on top of these traditional risk factors, genetic risk research, imaging risk research, intervention modeling, to really give you a flavor. Number one, what your personalized risk may be, what your estimate may be. And number two, what you can actually do about it, right? And so that closes that critical gap, because this is what I want my oncologist to do for me. I want her to have the intervention modeling so that she can go beyond the research studies and the population-based estimates and really give me my risk, because this is what's important. And I want to give you your risk. And so here I'm just going to demo this tool real quick. So I'm going to stop sharing just for 1 little minute, simply so that I can enter my credentials. And there is no need for you to know what my credentials are, because your doctor, if they do sign up, they will establish their own credentials. And by the way, this system requires something called National Provider Identifier, or NPI. This is a number that in the United States, most physicians, registered dietitians, nurse practitioners, physician assistants, they all use these numbers. And so this is how we know who you are. So what I wanted to show you is that now I'm in the risk console, and I wanted to show you a couple of cases. They're demo cases. So when your physician or your healthcare practitioner happens upon this, they will see exact same thing that I'm seeing right now. These are all based on real people, right? And so I wanted to bring it forward to show you that real people can benefit from this. So let's, for example, if we take this case here, this is a case of a woman. She's in her 60s. She's receiving bioidentical hormonal replacement therapy, and she tends to run higher lipids. You know, her LDL cholesterol is elevated. It's 126. Her HDL cholesterol is very reasonable at 75. Her triglycerides are fairly good. Her hemoglobin A1C fluctuates somewhat. You know, sometimes it goes into that pre-diabetic range, sometimes it doesn't. She doesn't really have weight to lose or fat to lose. She's actually very skinny. And I suspect that, she potentially might be the so-called lean hyperabsorber, somebody who absorbs a little bit too much cholesterol from food, or potentially maybe somebody with very mild tissue level insulin resistance, because she certainly could stand to build more muscle. She doesn't really have fat to lose. But she's worried, right? She's very worried about those elevated cholesterol numbers. And when we put the numbers into the assessment, we could see that, she doesn't really have high risk features. She has great blood pressure, but she wants, considering that she's really doing a lot for her health, she wants her total cholesterol and her LDL cholesterol and her ApoB to be as optimal as possible. And they're not, right? If you listen to my episodes previously, you know that I usually tell you that LDL cholesterol of 70 and ApoB of 80 or so, almost everyone would agree that those are optimal. And usually this is kind of the line that we try to cross for higher risk patients, for really high risk high-risk patients, we try to go even lower, right? We want to shrink their plaques, we want to reduce their risk. So we try to go to LDL cholesterol less than 55. And, the European colleagues just published in August of 2025 that less than 45 may even do the trick, right? So we have all these metrics. Again, they're population-based metrics. But this person in front of me, what she's asking, should she be that low, right? What is the answer that we're going to give her? Now, fortunately for her, because she's been really working on herself, while she had some success, she also had some things that are not so successful. For example, her inflammation parameter is a little bit high. Her high sensitivity C-reactive protein is elevated. But she basically has a little bit of a carotid plaque present, which is not unusual for somebody in their 60s. So she has some markers that potentially this elevated level of cholesterol could pose a risk, right? She also had genetic data with us. And so you could see now that we are going beyond the standard computations, and I'll show you where it matters, trying to figure out how does all of this together compute for this particular individual. Not for population, but for this particular individual. So we're bringing in her genetic analysis. We're bringing in something called polygenic disease risk scores, and your doctors will know what that is. We even bringing in information about her possible adverse reaction to medications such as statins, right? Because we don't want to cure one thing, but hurt her with regard to another thing. And so we proceed then to our risk score simulations and, continue to our results. And so let's see what her results actually look like, right? So we kind of thrown all of this together, right? We've thrown her risk, her cholesterol levels, some of her imaging data, some of her genetic data, which is actually very powerful because it helped us to shift her risk. And you can see by how much it shifted her risk by 25%. It brought her risk down because she has some very important variants here that we had to take into account. And so you could see that for this lady, even though her lipid levels tend to be on the higher side, it is actually not computing to a very high risk level. And she potentially could get away with just managing this dyslipidemia with supplements. Now, of course, there are a lot of things we don't quite know. For example, we don't know her most recent coronary artery calcium score. She had it a couple of years ago, and she was at 0. We typically don't repeat these scores until at least 5 years out. But, maybe considering that her inflammation level was a little bit on the higher side, we should repeat it a little bit sooner, right? So there's still areas of uncertainty. But now we are in the area where we can bring together not just these standardized scores. And you see, this is what her standardized scores are giving her if we only looked at the reference population, right? Without taking her genetic variants into account, without taking her imaging data into account. If we look at her through just the population lens, we're going to say, well, depending on a risk calculator used, she goes anywhere from low to intermediate. And, in the intermediate zone, this is where we're going to start discussion with a patient. Do they feel like they want to have additional workup, perhaps additional, consider some medications, statins or non-statins? And, and this lady, she is already doing a lot of things for herself that she feels are working to optimize her health. So it's not really somebody who can, lose 20 or 30 pounds or stop smoking or start exercising because she doesn't fit any of those boxes, so to speak. And so powerfully here, because we're able to risk stratify based on her unique profile, when we apply her genetic studies here, we could see that from genetic adjustment alone, where her polygenic risk scores actually put her in the lowest risk category versus, again, the population of people whose genetics was evaluated in a biobank, that actually starts to reduce her risk, right? This is not a perfect calculation. It's a very simplistic calculation, but this is a model. This is a construct. This is what we try to bring together in order to give patient and their physician a path forward. And a path forward here is not going to be a statin drug because her risk is low to intermediate and she's not really willing to do the statin medication. So we opted for 2 supplements here. You could see here I'm loading a preset, that we have in this console, and your doctor will be able to do the same. And I can, manipulate the doses, for example, on this preset, and I can save the simulation so that as a physician, I can share it with my patient. And so your physician will be able to do the same. I didn't give her any medications. This is my proposed treatment here. What I'm trying to do here is to simulate what will be the outcome of this approach, right? So we potentially, you could see here, could reduce her LDL cholesterol into these more optimal ranges. And with that, being in this more optimal range, that certainly is more beneficial for her long term than the higher ranges she's with right now. But at least based on the information that we have provided, she doesn't necessarily has to use medications, certainly not aggressive medications. Of course, this could potentially change if additional information comes into the mix. For example, if she goes for coronary artery calcium score and repeats it, and maybe we do CT angiography, we may learn a bit more about her vascular lining and her vascular age. And that, of course, could readdress or redefine what is happening here. And your physician can use this little button here to generate AI-assisted summary in real time. Now, this is real-time research using academic mode from Perplexity, which is one of those AI platforms that allows you to do real-time research, but real research with citations. So this is not a black box. This is just a synthesis of information that AI is helping us to get fairly quickly. And because it's real-time guideline, you see that, it takes a little bit of time because it needs to go and do this search and present this search to us. But this search will be very powerful and helpful to our patient because this search will allow them to understand what is it that they should be doing and what is it that they don't necessarily need to be doing at this point in time. And the great opportunity here, and we're going to come back to this screen. I guess it got scared that I wanted to navigate away. You could see that it explains to you, the patient, and to your doctor, what your risk is, what risk category you're starting with, and why. How that risk may change over time. And again, these are only statistical projections, right? We're looking at these 30-year projections, lifetime risk. These are all statistical calculations. We don't know for a fact if that's your risk or not. Your risk could be higher or lower or very similar to that. We don't really know that, but we're trying to get to that. And so additionally, you can learn using this engine about cardiac kidney metabolic profile because, as I mentioned already, so much of dyslipidemia is actually cardiometabolic, right? It reflects insulin resistance, whether it's local insulin resistance or more systemic insulin resistance. It does not only, insulin resistance is not something that only happens in people who are overweight. It is one of the fundamental things that changes with age when we lose our insulin sensitivity. And there are actually people at both sides of the spectrum, people who are significantly overweight or have high amount of so-called visceral fat, and people who don't really have high amount of visceral internal fat, but they're skinny and they don't have enough skeletal muscle, so we call them under-muscled, and they also will show insulin resistance, right? But so it provides some guidance for you to understand where are potential areas for improvement, right? It talks to us about your inflammation profile. It takes into account the genetic factors that we are seeing and how they may be influencing what this patient needs to do, whether it's a certain nutritional pattern or supplementation. We didn't pick medications for her management, but we did pick supplements. And these supplements are picked for a reason, because they align with what we know about her in terms of the mechanisms that are likely to account for these elevated lipid numbers, as well as her genetics. And because it is an AI agent, we want to also have information that is relevant to safety and drug interactions. And you could see it here that information is provided. And these are the real-time clinical sources. So it's not a black box AI. You're not going into ChatGPT or Gemini or Claude and just asking it questions, trying to figure out where it's pulling this information from. This is not happening here. What is happening here is that we have a core body of knowledge, our knowledge base, that is from highly regarded cardiovascular scientific publications, and we update it pretty regularly. And on top of it, we're performing real-time clinical academic search to bring you this advice. What we are doing, we're leveraging the capabilities of AI to do it in real time, right? Previously with my patients, I would do this on my own time, so go ahead and, do the research and put all of these things together using, this AI up here. But, this AI up here in my head is still, I'm still the human in the loop, and I'm the human driver. What I am doing here is that I am leveraging the capabilities of this new technology to get the level of insight in real time that my patient actually needs. And so I am very excited about the Heartwell AI tool. I think this tool will absolutely change so much for our patients, and it definitely bridges the gap in in how we evaluate patients clinically, how we forecast cardiac risk, how we are capable of showing patients what potential considerations they have, so that they can go ahead and really understand what are their best options, right? And so I wanted to show you just, one more case here so that you can understand the value of this, because this is a patient that I just saw yesterday. And so I'm going to go ahead and just give you an understanding who this patient is. So let me go ahead and quickly going to share my screen one more time here. And so this patient, very lovely patient, who is 70 years old, again, not really overweight, not a smoker, not a drinker. They happen, both of these patients happen to be women, but the use of this is not limited to women. It's just the patients that came through that I wanted to show you. And so the concerning part is that this patient actually went into menopause fairly early. She went into menopause in her late 40s, and she hadn't really received systemic hormonal replacement therapy. As you know, the views on hormonal systemic therapy have changed over time. And now we have more availability and more opportunity to use hormonal replacement therapy. But, back then, 20 some years ago, when she was in her late 40s, that was not the case. And so what happened with this patient is that she's been a patient who's been running elevated cholesterol. And you could see it's not really terrible. Her LDL is 146, her ApoB is 112, so it's not off the charts. She has no signs of inflammation, but because of her age, and she doesn't even have family history, and these mildly elevated cholesterol numbers, her doctor sent her for coronary artery calcium score. And what happened with that coronary artery calcium score is that it came back a whopper of a score, right? So what we entered all of her parameters here, and I'm going to go ahead and show it to you. And so her coronary artery calcium score was almost 644, which placed her in the 90th percentile for age and gender. What that means is that she's in the top 10 for her gender in her age group with regard to calcium buildup in her coronary arteries, right? So she's leading the pack in a competition that we don't ever want to win, right? We don't want to be in the top 10% for any disease, especially advanced disease, because this is accelerated atherosclerosis. And when I started looking at her genetics, I realized that she sort of has a perfect storm because she has genetic variants that are predisposing to so-called endothelial dysfunction. And we test for all of these at the Holistic Heart Centers using our Heartwell toolkits, or just, if you had your labs and you don't need the full toolkit, you can just use the genetic panel. So all of this is accessible. And she has other genetic variants that are fairly unique. They're usually not, the most common ones we think about. They're so-called TR3, but they are actually making her good cholesterol turn bad. And I would like to invite you to listen in the next 1 or 2 episodes. We're going to have an episode that will be devoted to just that. It will talk about when your good cholesterol turns bad, what that it actually means. But this is her situation. And this situation has to do with something reverse cholesterol transport, another sciencey concept that I will absolutely 100% explain to let you know what it is. And her primary care doctor, the one who sent her for the scan, already started her on medication. They gave her a very low dose of medication of rosuvastatin, 5 milligrams. And now, they're sort of at crossroads, right? Is it going to be enough? Is it not going to be enough? What do we actually need to do for this patient? Now, that the question that you need to answer to yourself, the one, if you've been listening to this episode, you know what the answer is. We need to figure out what her risk actually is. And so your doctor should run through these calculations. These are our standardized risk estimators, those population-based risk estimators. And you could see that these estimators are forecasting, a scenario that could be worrisome because they're putting her at the intermediate risk group based on the combination of factors: her cholesterol levels, her blood pressure levels, smoker, non-smoker, and of course her coronary calcium score, which this particular calculator here, MESA calculator, is essentially giving us an understanding. And this is something that, is very challenging for a patient to see this and to experience this. But this is just statistics. The statistics is telling us that this patient who is 70 has an arteries of a 100-year-old person, right? So they achieved, presumed longevity, but it's in longevity in the wrong place, right? So this is just a very, troublesome finding that this woman has accelerated atherosclerosis. But you could see that because the genetic data is not commonly included in risk estimators. And because a lot of patients may not even get a calcium score, a lot of doctors may not even think of putting the calcium score out there for a patient like this in her 70s who has mildly elevated lipids, right? These are not the type of lipids that are off the charts. She doesn't have a lot of inflammation going on, but there's some sort of factors of risk, some risk enhancers like early menopause, not having hormonal replacement therapy. But what you're seeing here is that these standardized calculators, because they're sort of old and a lot of the time they draw on pre-existing populations, they give us a forecast, but this is sort of like a weather forecast that may change at any time, right? Because we don't quite know, is the person really well represented by these statistical population-based metrics or not? And so in her case, we have, 2 very powerful pieces of information. We do know that, the coronary calcium score is really high, and, that would up her risk estimates manyfold. We know that her genetic variants are also very bothersome, and they sort of cluster in the type of a pathway that is virtually guaranteeing her coronary artery disease, which is what she actually has. So if we try to manipulate this and we say, okay, well, let's factor in with genetics on board, you could see that all of a sudden, her scores are kind of, quadrupling themselves. And if we put the imaging information in, we know that her score is very high. And, it makes sense because she already has coronary artery disease. So the 30-year risk of event is also very high. And so it is not going to work for her to be on a low dose of one medication, statin medication. It is not going to bring her in a good place. And I can model it for you and for this patient. If I'll bring it over here, this is the dose she's on, rosuvastatin 5 milligrams. You see that she had some reduction in her LDL and her ApoB. They're reasonable reduction cutoffs. They're not good enough for her level of risk, right? Because she will be that individual where we would like to see LDL less than 45, ApoB less than 50 or 60, as low as we can possibly get. So she's on her way with this low dose of rosuvastatin. She's just not going to be at goal. And because her baseline risk is so high, we are really not, meaningfully reducing it. So instead of doing this, I was able to work with this patient to make her understand that a much higher dose of rosuvastatin should work for her because of her very specific genetic. We would be adding something called ezetimibe. And you could see here that, it begins to shift how her LDL behaves, the combined behavior. She's beginning to start approaching those levels where we could potentially see stabilization of vascular disease and even some plaque reversal, right? The jury is still out of that. And I actually will use the triple therapy, right? That PCSK9 inhibitor, because we need those numbers to drop, right? And this is what helps a patient, and this is what helps me decide which direction to go. We are on the same page, right? And so patient may decide to proceed with this recommendation. They may decide not to proceed with this recommendation. They may think about it. They may ask questions, but now they're informed. They understand about the synergy between medications, and they understand that supplements are just not likely to do this. And if you ask me, well, how do you know supplements are not likely to do this? I can model the impact of supplements as well. I'm going to go ahead and, give her some of the bergamot and berberine that, we potentially could use. And you could see that while it certainly brings the numbers down for LDL cholesterol and ApoB, and you may say, well, that's good enough. With all the interventions, it didn't really bring her risk low enough. She's still in that high risk group. That's why my preference for her, given her specific situation, was to go into the triple therapy, right? So this is that fire and forget approach that some cardiologists are advocating, but I'm not firing and I'm not forgetting. I'm working with this patient in a shared decision-making situation to make a difference. And where we're getting with this Heartwell AI, is that we're currently in the process of collecting the outcomes from practitioners who practice like this, cardiologists and primary care physicians, so that we can give each patient a sense of their own trajectory, right? This is called a digital twin exercise, or digital twin in general. And so this is an opportunity for this patient to go ahead and to understand what they might expect. And if they do decide to take medications, or if they do decide to take supplements, once this new information comes in, we can adjust the scenario, right? So this is a very proactive hands-on management. This isn't telling a patient, here's a population, here's your risk. You may or may not be similar to people in this population, but here's your forecast, deal with it. It's like saying, oh, here's the, weather forecast, go ahead and take an umbrella, even though what we're really trying to forecast is a climate crisis, but we're treating people with an umbrella at the moment because there's a certain probability of rain in the near future, right? That's what these population risk equations, that's why they're at the floor, that's why they're the base, because they are giving us this mostly short-term estimate and occasionally 30 or lifetime estimate that we can potentially factor into our decision making, right? But yet we're altering this patient's life by potentially asking her to be on 3 very powerful medications that will lower her total cholesterol, will drop her LDL cholesterol, will drop her ApoB. She may have some side effects with that are not related to cardiovascular side effects, whether it's poor healing or issues with the immune system or potentially things that have to do with memory, although she doesn't have any of those concerns, but if she does, we can come back and retry our modeling to make it as personalized as possible. And you could see here that, this is what we gave this patient. We explained the risk. We explained all of her profiles, her cardio-kidney metabolic profile, her inflammation, how her genetic factors are playing a role, what lifestyle interventions she may go on, what the medications are and how they work, and why we think that they will accomplish what they will accomplish, what potential drug interactions we need to consider here. Here, there is no adverse interaction, there's actually synergy between medications, but we are likely to, of course, monitor her response. In about 12 weeks or so, she'll have another test if she goes or adjusts her medications to understand where she ended up. And you could see that, there is a scientific rigor behind it because we are pulling from information that's available in the moment. And that's one other thing to understand is that the guidelines, the equations that you had seen, that information had already been published. It doesn't usually get updated very often, maybe once every few years. But the science gets updated quite often for things that do matter to our patients that are not reflected in the guidelines. And that's why this real-time clinical scenario is so powerful. So I wanted to really bring home this point is that just like myself, with my tamoxifen and my doctor, I am searching for solutions that are important solutions to figure out, what should my personal trajectory be? How can I affect my personal trajectory, right? And the same is for you, right? What should your cardiovascular risk trajectory be? How can you impact your cardiovascular risk trajectory? If you're telling me, oh, doc, I liked all of this, but I'm going to go right now and exercise and have a good diet and normalize my sleep and stop smoking. This is all great. And you absolutely should do all of this. But you should also understand that there is value in additional testing because it allows us to create not just a weather forecast, but a climate forecast for a specific area. And in this case, it's you. And that allows us directionally to put you on the right path. Because how do you know how much you need to exercise? How do you know how much you need to diet? How do you know what diet you're supposed to take? How do you know which medications you're supposed to take or which supplements? If you're still hanging your hat on those population-based metrics, you're basically missing 2/3 of the things that could actually impact you. And this is not me saying this. This is the data saying this, because we know, for example, that even with the best medical therapies for cardiovascular disease, coronary heart disease in particular, we're able to drive a 30% risk reduction, right? It's a relative risk reduction. It means that if your, risk is 10% in 10 years, we give you the medication, that risk will drop threefold, which is not, small, so it will drop, by 30%, right? So you will end up a little bit less than that, you will end up maybe like a 5 to 7% or so, right? But you could see that the majority of risks still have not reversed itself, right? So, if you were 10% and you now, decrease to 7% or 6.5%, that's still, most of the risk is still there. And in cardiology, it's called residual risk, right? So we know that even with the best therapies for cardiovascular coronary heart disease, we are usually, there is a ceiling in our relative risk reduction. It's about 30% or so, some, plus and minus on either side. And so that leaves another 70% of your personal risk untouched. And unless you're able to understand what it is, and these days it is not that difficult because we have these advanced biomarkers, we have genetic markers, we have imaging. They're not for research anymore. They're for real clinical care. They should be used for clinical care. And we have tools such as Heartwell AI that can actually give you a personalized risk estimate. So this is American Heart Month, February. I encourage you to take advantage of the opportunity. If you are not scheduled to see myself and my team, you can certainly invite your doctor to heartwell.ai, have them run through it and give you an understanding. You'll certainly learn a lot. If you would like to work with us, you can schedule your services right on our website, and you will see that for the entire month of February, heartwell.ai is a free add-on available to all of our consults. And with that, I want you to really be grateful to yourself, be grateful to your heart, and to understand that you have options, you have solutions. And in 2026, if you even compare it to just a few years ago, we are having so many opportunities in figuring out the best option, the best plan for you, that you can take advantage of them all. But the primary person who is responsible for you being successful is you. Because if you don't take that next step, changes are not likely to happen. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Heart Centers. If you enjoyed the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticheartcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.